In this particular video, we're going to talk about diagnosis. Now, in the previous video, we talked about the assessment process, right? We talked about how we gather information to come to some understanding about our client. Assuming that we have sufficient information, we might come to a diagnosis. So the question we're asking ourselves is, does the client's syndrome match a known disorder? So we take all of the information of the assessment, put it together to paint a clinical picture. And the diagnosis, if warranted, would be the taxonomy or classification of a given condition. So we use a classification system. Now, I will tell you that the one we use in the United States is called the DSM. Internationally, they use the ICD. So there isn't a single classification system that is agreed upon by everyone. Now, as I said, we have the DSM-5, which is our Diagnostic and Statistical Manual for Mental Disorders. It's in its 5th edition, right? That means there was a 4th edition, a 3rd edition, a 2nd edition, and the original DSM. You also will see that we have the text revision. In 2022, there were some text revisions to the DSM-5. So currently, you'll see it written as the DSM-5 TR, text revision. And what the DSM-5 does is it allows us to break diagnoses down into categories of clinical syndromes. It can put you into a category, but I will say one of the things that the DSM-5 does is also have some spectrum-based conditions. So, and the most popular one you might hear is autism spectrum disorders, right? So that isn't just a category of a diagnosis, it's the degree to which there are deficits in social functioning, language, IQ, and so forth. And people on the autism spectrum vary significantly on all of these domains. So there are some conditions that we can't just use a taxonomy or a categorical process. We have to use a spectrum base. But you might ask yourself, well, are these classifications reliable and valid, right? Because if we're going to diagnose, then we're hoping that our diagnoses are consistent from person to person. So if we're asking, are the reliabilities or are the classifications reliable, we're really asking is, if I give you a psychological assessment and another person gives you a psychological assessment, would we come to the same or very similar diagnoses? Well, I will tell you we do a much better job today than the original DSM. So the DSM-5 has tremendous inter-rater reliability. So why? Because we use field trials. So the DSM-4 and the DSM-5 use field trials to increase reliability. But it's not perfect, so reliability is still a concern. What I will tell you is my experience is that if I give a psychological assessment and another clinician gives a psychological assessment, even if we come up with different diagnoses, they're usually in the same family or very similar. So if I give you, let's say, paranoid personality disorder, right? That's a diagnosis. And someone gave schizophrenia with paranoid features. Well, it's a different diagnosis. We shouldn't miss that far, but they are still, both of those diagnoses are anchoring in on the paranoia. Now, what I would tell you is that if I gave the diagnosis of paranoid personality disorder, it's because I don't believe that the person is detached from reality to be in a severe psychotic state. They do have paranoia. It is global, but the psychosis, that the hallucinations and delusions that are oftentimes present with schizophrenia were not present. So that's why my diagnosis would be such, let's say. But reliability is a concern. If we don't have perfect consistency, then I'm not going to say that every diagnosis a person gets is accurate. And it is not uncommon for a person's diagnosis to change. Let's say a person was in treatment and they got a diagnosis, and then the person concludes treatment, and then sometime later in their life, they say, oh, I was diagnosed with X. Hopefully, the clinician is going to do their own assessment. And it's not uncommon for the clinician to say, hey, wait a minute, I see things differently. So reliability, we have to be mindful of. Now, validity refers to the accuracy of information, right, that these diagnostic categories provide. And the biggest type of validity we look at is predictive validity. So for diagnoses, does this diagnosis predict a specific outcome? For example, having a learning disorder, does that predict poor academic attainment or achievement, right? We'll use that as a form of predictive validity. DSM-5 has greater validity than the previous editions as well. And you might say, well, why is that? Because if you get your hands on the DSM-5, you'll see that there are extensive literature reviews. And the current edition of the DSM is based on the state of research today. So these extensive literature reviews, these field trials that we do, increase the predictive validity. But validity is still a concern. So when notice I'm teaching you about the DSM, I'm teaching you about diagnosis, but I also want you to be able to be critical of the DSM as well. I don't want you to think, okay, well, this is what the DSM says, so it must be right. There are issues with reliability. There are issues with validity. And another question you might say is, well, is there a problem if you come to the wrong diagnosis? The answer is yes. Because if you come to the wrong diagnosis, then that diagnosis informs your treatment. So you're going to, that diagnosis is going to affect how you interact with that client or can. Now, again, a lot of times this happens when we're relying exclusively on clinical judgment and not engaging you with screening instruments or other forms of tests. The other issue is when we convey a diagnosis to you, how are you impacted by that label? And we know that there is a stigma around mental illness, and people are going to view themselves differently based on giving them a label or giving them a diagnosis. We also know society is going to relate to this individual differently. So we have to be careful with the problem of a self-fulfilling prophecy for our clients. So if I say, okay, this person has, making up another one, bipolar disorder, a person could say, oh, well, I was just manic, and engage in impulsive behavior and use the diagnosis as the rationale why they engage in the impulsive behavior. That's a self-fulfilling prophecy. Now, other people will treat you differently as well. And I want to share with you a study that was done in the 1970s by a researcher by the name of Rosenhan. And what he did was he wanted to demonstrate the power of labels in diagnosis. So he taught his students how to present as if they had schizophrenia or another severe mental illness. And he had them go to a psychiatric hospital and express concern about their made-up psychiatric illness. And what Rosenhan said was, as soon as you get in, I want you to behave normally. I want you to stop showing any symptom of the fictitious disorder you started with. And Rosenhan wanted to see whether or not the clinical staff in a psychiatric hospital would catch it, that they made a mistake. And time went on and they didn't. So Rosenhan said, I can't keep my students here forever. So he shows his research protocol and says, well, these are my students. You have to let them out. They do not have this illness. And what he found was normal behavior was viewed more pathologically. What do I mean by that? So these students were taking notes on their experience and how the staff related to them. And in the charts, there were comments of excessive note-taking, or if they were walking on the unit, excessive pacing. Now, you would think that after Rosenhan shows that this is not true, these individuals did not have a disorder, they would say, okay, my bad. But even when they discharged, they were labeled with diagnoses like schizophrenia in remission. What does that mean? The person was diagnosed with schizophrenia, but the symptoms are no longer manifesting. They never admitted that they treated these students differently based on a label. Pretty powerful, right? So we do know that there is a stigma related to mental illness. We do know that people will interact with a person with a diagnosis from time to time differently or view them differently. And we know our clients might start to behave in accordance with a given diagnosis. And I will share with you, I very rarely have my clients ask, well, what's my diagnosis? You would think that this happens every day. Your client wants to know, okay, well, what's my diagnosis? You know what? People who come into therapy are oftentimes focused on getting better. And therapy is oftentimes about addressing the symptoms of the disorder, not the label itself. So if it's not directly addressed, I focus on the behavioral features, the cognitive features, the emotional distress factors, the motivational factors linked to the disorder, not the label itself. So that is our concept of diagnosis. So we have our assessment, which allows us to come to some kind of understanding of what the person is struggling with, and we can label that, put it into a category or a spectrum-based condition. But now we have to talk about treatment. And I'm going to put treatment in its own video. So I'll stop the recording here.